Wonderful. Good afternoon, everyone. Welcome to Assembly Committee on Health and Human Services. We have a huge day today. And members, before we begin, please remember to mute your microphone when you're not speaking, just to minimize any background noise. And also, please, if you have to turn off your camera, please leave your camera on, but so the staff can make sure that we have a quorum present. And if you do need to step out or be excused, please reach out to myself or Vice Chair Peters so we can note that for our own records. And so at this time, let's get started. Madam Secretary, will you please call the roll?
Assemblywoman Benitez Thompson, Assemblywoman Black, Assemblywoman Garlow,
Here.
Assemblyman Hafen,
Here.
Assemblywoman Krasner,
Here.
Assemblyman Matthews,
Here.
Assemblyman Orentlicker,
Here.
Assemblywoman Peters,
Here.
Assemblywoman Summers Armstrong, Assemblywoman Thomas,
Here.
Assemblywoman Titus,
Here.
Chair Wynn.
Here. So it appears that we have a quorum, so we are ready to go. I know that some people have been having some technical issues, so if we can just mark Assemblywoman Benitez Thompson and Assemblywoman Black absent excused and note their presence if they do return. Let's get started. I'd like to welcome our audience joining us either virtually on the website, legislative website, or on YouTube. Today, we have presentations on mental health here in Nevada and two hearings on two bills. And I realized that I might have been overly optimistic when scheduling this agenda, but I know that we are all ready to start making good policy for our state, and so we will be able to power through this. I'm very confident in this committee and our ability to get through and get this hard work done. So before we begin, I'd just like to make several housekeeping announcements. Agenda items may be taken in a different order than listed. Two or more agenda items may be combined for consideration or removed from the agenda, or discussion of an item may be delayed at any time. This is a virtual meeting format via Zoom, so it's important to keep everyone safe and also have access to the public. So the public may provide testimony in several different ways, all of which are listed on the agenda. Right now, you can register to participate online through the legislative website, Nellis, or by sending your comments directly to our staff. Any committee exhibits may be submitted electronically. You can see them online for our members, but as well as the public. And we will try our best to keep that as up to date. I know that we have our committee manager, Abigail Lee, is fantastic about getting that stuff up and running, so we all have access to it before our meetings. If you are not able to submit public comment over the telephone at the end or during the presentation of the bill and the bills today, you would be able to do that in writing. And so you just need to get that to our committee secretary 48 hours after the meeting adjournment. So with that, let's move on to our first agenda item. I'm just so thankful that our presenters are here and available for us. I know that they could talk for hours and days and weeks about mental health, and especially the status of mental health in our own state. And I have asked them to reduce that down to 20 minutes. I will try to open it up for some limited comments or questions from our members. But I would encourage you, and I believe our policy analysts will send out all their contact information. So if you are not able to ask your questions today under these limited circumstances, I encourage you to reach out to them. I know that they have been very forthcoming with information when I have needed it, and I am sure they will be that way with all of you. So with that being said, I would like to start off with our first presentation from the Department of Health and Human Services and welcome Dr. Megan Freeman, the Clinical and Policy Advisor on Children's Behavioral Health, Division of Child and Family Services, as well as Dr. Stephanie Woodard, the Senior Advisor on Behavioral Health, the Division of Public and Behavioral Health, So if you guys could please introduce yourself, and I'll remind all of our members and our guests to identify yourself before you speak so we have a clear record going forward. And I'll just turn it over to you guys right now.
Great. Good afternoon, Madam Chair and members of the committee. My name is Stephanie Woodard, and I am the Department of Health and Human Services Senior Advisor on Behavioral Health, and I'm joined this afternoon by Dr. Megan Freeman, the Clinical and Policy Advisor on Children's Behavioral Health with DCFS. We're here
Hello,
to...
this is American Broadcast. Oh, never mind, you fixed it. Thank you.
We're good. Okay. We're here today to provide a brief overview of the state of Nevada's behavioral health system, discuss the impacts of COVID-19 on behavioral health in Nevada, and opportunities for behavioral health going forward. This presentation is intended to be very high level as an introduction to the state system, and we recognize from the outset that the behavioral health system is vast and incredibly complex. We're not going to be able to go into much detail here, but both myself and Dr. Freeman are available for questions following this presentation, as well as offline if there are any specific issues or topics that you'd like to learn more about. So there are lots of different departments and divisions within the state of Nevada that have touch points to behavioral health and play a critical role in ensuring that services and supports are provided within other systems such as criminal justice. But the Division of Public and Behavioral Health, the Division of Child and Family Services, and the Division of Healthcare, Finance, and Policy all function together under the Department of Health and Human Services to provide essential elements for the statewide community-based behavioral health system. Behavioral health in Nevada has evolved over the past decade, especially with the implementation of the Affordable Care Act. These state-driven systems have helped to expand access to care, when previously the state itself was the largest behavioral health provider in Nevada. This evolution has required a lot of concerted effort and coordination across divisions within DHHS, and DPBH serves as the state mental health authority and the single state authority for substance abuse treatment and prevention. Collectively, the three divisions work together to plan, provide, regulate, provide oversight, training and technical assistance, and financing to this very complex system. In order for us to do the job of planning and the oversight that we provide to the state behavioral health system, we have several boards and commissions that help to guide our work. These include the State Board of Health, the Regional Behavioral Health Policy Boards, which you're going to be hearing about in a little bit, Behavioral Health Planning and Advisory Council, and the Substance Abuse Treatment and Prevention Agency Advisory Board. All of these collectively have in one way or another an opportunity to provide planning, oversight, and regulation and advocacy for behavioral health in Nevada. The Division of Public and Behavioral Health has several priorities moving into this biennium, and they include things like evidence-based forensic services, improved behavioral health through promotion, prevention, early intervention, and access to quality behavioral health services, and really to continue to improve that inter and interagency communication for collaboration. So a brief overview summary of what the behavioral health system looks like in Nevada, specifically as it relates to the Division of Public and Behavioral Health. As the State Mental Health Authority, we have direct services in both civil and forensic. We also provide a high level of policy advisement, and we manage a number of federal and state grants that are used oftentimes as pass-through to community programs to assist in prevention programming, as well as to support community behavioral health providers to establish new programs. We also work with those programs towards sustainability, and we also use some of the funding to help provide services for individuals who are uninsured or underinsured. The behavioral health system also includes the Bureau of Healthcare Quality and Compliance. Next slide, sorry.
A little delay.
It's okay. And they often assist with the licensure of healthcare facilities, including some of the real foundational facilities, part of the behavioral health system in Nevada. And then we have the administrative services, which are absolutely essential for us to be able to administer the grant funds that we receive. Next slide. So for our clinical services on the civil side, we have 2 inpatient psychiatric hospitals, Northern Nevada Adult Mental Health and Southern Adult Mental Health, both in Washoe and Clark County. The access to inpatient services, more often than not, is for an individual that is admitted under an emergency through a mental health crisis. However, they do also have voluntary admissions. There are several outpatient clinics that also make up a network of care within our state. There are 4 of these clinics in urban areas, 3 in Clark and 1 in Washoe, as well as 18 clinics that are community-based throughout rural Nevada. Access to outpatient services is completely voluntary unless the individual has been ordered to mental health court or assisted outpatient treatment. It's important to note that our civil service outpatient programs really do provide the safety net services for individuals in Nevada who are uninsured or underinsured. They also work very closely in collaboration with community partners to provide a no wrong door approach on the campuses of both NAMS and SNAMS, but they also provide a coordination of care with many community-based programs. In addition to the community-based programs that they work in, they also provide an array of services related to outpatient mental health services. On the forensic side, we have 2 hospitals in Nevada, Lakes Crossing in Sparks, Nevada, and Stein Forensic Facility in Southern Nevada. These 2 hospitals work with individuals who are working towards restoration of competency. They also have long-term inpatient forensic programs for individuals who are committed to the division and are also serving individuals who are acquitted as not guilty by reason of insanity. These forensic hospitals have been working very hard over the last several years, next slide, to assist in addressing the federal consent decree around the inability for the state's single forensic hospital to admit all court-ordered referrals in a timely manner. They have recently been able to move out of the consent decree, but it's important to acknowledge that the forensic hospitals still are either at or near full capacity. So although the consent decree has expired, without penalties or further oversight, the state is continuously focused on careful management in order to meet demand and avoid any other legal challenges. So those are the 2 areas where there are direct clinical services that are provided within the Division of Public and Behavioral Health on both the civil and forensic side. But as we have worked to move away from being the largest behavioral health provider in Nevada and really building capacity at the community level, we have recognized the need for additional support to help build that community capacity. The Behavioral Health Policy Unit works to administer the majority of our large federal funding streams that are used to address specific populations, including those who are uninsured and underinsured. This also requires the policy division to work on additional supports, such as technical assistance, strategic planning, and implementation of systems within the state and in communities. Next slide.
There's a little delay.
Okay. Some of the behavioral health policy areas of focus include addressing minority health inequity and disparities, supporting evidence-based practices. We did a lot after COVID to help support community agencies to fully implement telehealth, and a focus on suicide prevention and crisis services. That is my very brief overview of the behavioral health system as it relates to the Division of Public and Behavioral Health. And I believe now I'm going to be handing it over to Dr. Megan Freeman at the Division of Child and Family Services to provide a similar overview of their system.
Dr. Megan Freeman with the Division of Child and Family Services for the record. Thank you, Dr. Woodard. Good afternoon, Chair Wynn and members of the committee, and thank you for the opportunity to present to you on children's mental health. Next slide, please. Today, I'd like to give you an overview of our agency operations and explain how our work shapes the children's mental health system in Nevada. Next slide. On this slide, you will see our agency.
Excuse me, Ms. Freeman, this is American Broadcast. We are unable to see your screen share, so I am going to stop it for you. And if you could bring it back up, that would be great.
Are you able to see the slides now?
I am, and all right, everything looks great. You may proceed. Thank you.
Great.
Okay, thanks. Thank you, Joseph. Dr. Freeman, for the record. On this slide, you will see our agency vision and mission. In seeking to improve conditions for youth in every Nevada community, what we mean is that we seek to break down barriers to access to care in every region across the state, to eliminate disproportionality in our systems, and to meet the needs of special populations. Next slide, please. In addition to our agency vision and mission, 3 regional children's mental health consortia guide the growth and development of our children's mental health system. The makeup and roles of the Children's Mental Health Consortia are defined in Nevada revised statutes, and the consortia chairs and myself will speak to this committee on February 15th in more detail about this. Next, I would like to touch on another important value system that guides our work. Nearly 30 years ago, a federal initiative known as the Children's Mental Health Initiative was authorized in order to facilitate the delivery of comprehensive community mental health services to children and youth. Through this initiative, hundreds of demonstration grants, cooperative agreements, and expansion grants have been funded throughout the US to encourage the widespread adoption of what is called the systems of care approach. DCFS has received 3 grants under the Children's Mental Health Initiative and is committed to the systems of care, or SOC approach. The core values of an SOC approach include providing services and creating systems that are family-driven and youth-guided. Services are community-based, accessible, and provided in the least restrictive environment. And services and systems are culturally and linguistically appropriate in order to facilitate access. DCFS operations are divided into 4 separate areas, which you can see here. In 2019, DCFS underwent an internal reorganization to move away from our traditional orientation around children's mental health, child welfare, and juvenile justice services. This resulted in new coordination of our services around community-based services, residential or 24-hour services, and quality and oversight. Since the reorganization, we have been working to break down silos, incorporate children's mental health programming throughout the child and family service system, and incorporate continuous quality improvement into all programs at all levels in order to better serve youth, many of whom touch multiple of our systems. In our community service, oh, sorry, Joseph, can you go back? Thanks. In our community services area are located all of our outpatient, mobile, and other community-based services, including child protective and welfare services for rural Nevada. We offer services from ages 0 to 17 or into the early 20s if the youth is still enrolled in K-12 school. We primarily serve Medicaid fee-for-service, uninsured, underinsured, and undocumented families. For some programs, such as our mobile crisis response team, we serve any family in need at no cost. The focus of our residential services programs is 24-hour care. This includes acute care, residential treatment, and juvenile justice youth facilities. Our youth facilities are focused on programming and not punishment. Per policy, every youth receives an assessment for mental health and substance use treatment needs, and treatment is provided as needed. Our youth facilities also operate under a recently modernized suicide prevention policy. Our quality and oversight area is focused on policy, quality assurance, and DCFS and its oversight or regulatory role as a state agency. Additionally, our systems advocate is located in the quality and oversight area. This position functions as our public information officer and legislative liaison. DCFS Administrative Services is focused on support and infrastructure with the additional recent expansion of our victim services area. Nevada's Victims of Crime Compensation Program is located here, which provides financial support to individuals who have been a victim of a violent crime. Additionally, Victim Services holds Nevada's Anti-Terrorism and Emergency Assistance Program, or AEAP, a $16 million multi-year award to support victims of the Route 91 shooting on October 1st, 2017 in Las Vegas. Behavioral health support is a main focus of recovery for Route 91 survivors. Finally, through our Victims of Crime Act funding, we are providing funding for innovative programming that addresses the needs of children exposed to domestic violence and for victims of commercial sexual exploitation, including children. Next slide, please. In 2020, our psychiatric residential treatment facilities achieved accreditation by the Committee for Accreditation of Residential Facilities, or CARF. This was a multi-year, highly intensive process that has resulted in more in-state beds for youth with higher levels of need. In the coming biennium, residential services will be focused on implementing the Building Bridges program, a set of best practices for transforming systems to create partnerships and collaboration between families, youth, advocates, service providers, and oversight agencies. A primary goal of the Building Bridges program is to sustain positive outcomes after discharge from residential placement. Next slide. On slide 8, you will see our 2 active sources of competitive federal funding, including our Pediatric Mental Health Care Access Grant, which works to integrate pediatric psychiatry and behavioral health consultation services into rural primary care. Our Systems of Care Expansion Grant has multiple goals, but the overarching objective is system improvement, which will expand the service array in rural Nevada and provide infrastructure to grow DCFS's capacity to serve in an oversight role for children's behavioral health. In particular, the System of Care Grant will expand access to wraparound services, respite care, and family peer support. We've also been focused on supporting the implementation of a 1915I Medicaid state plan amendment to expand the service array for youth in specialized foster care, also known as treatment foster care for youth with intensive behavioral health needs. In our community service area, it's important to highlight the work of our mobile crisis response teams as a primary method or point of entry for families to access services and become matched to the correct services and supports for their needs. Using some emergency COVID funding, we were able to temporarily expand the mobile crisis program to meet increased need with 3 additional teams, as well as expanding our ability to provide telehealth services 24/7 statewide, when previously statewide 24/7 response was only available in Las Vegas. However, the funding is temporary. And finally, within community services, tiered care coordination is available to youth with multiple system needs in order to build the family's capacity to meet their youth needs, as well as match them to formal services and supports. Tiered care coordination includes high fidelity wraparound and a program called Focus for youth with intermediate level needs. So you will see that a lot of what we do is focused on direct services, but in our quality and oversight area, is where we focus more on policy and regulatory role. In our quality and oversight area, we're currently recruiting for a position that will be embedded at Nevada Medicaid to support policy development and on-the-ground technical assistance for schools implementing Medicaid billing. The position will have a particular focus on the Clark County School District as the largest district in the state. Looking to the future, there are significant workforce needs in quality and oversight. DCFS would like to move forward with becoming the Children's Mental Health Authority in Nevada, which would allow us to set provider standards, run a technical assistance and training center for evidence-based practices, and provide oversight and quality assurance to ensure that providers using public funding for mental and behavioral health care for children are adhering to standards and quality criteria. We currently lack the staffing necessary to stand up the technical assistance and training center or to scale up oversight and quality assurance. By creating an infrastructure for widespread dissemination and oversight of evidence-based practices, particularly home and community-based services, we can follow in the footsteps of other communities that have returned youth from out-of-state placements, closed residential treatment centers and juvenile justice centers, and achieve the system of care expansion goal of curating an array of effective, evidence-based, community-based treatment options. Our previous system of care grant identified the need for a Children's Mental Health Authority, and we were planning to begin those efforts during this legislative session. But given the current budget constraints, we're looking at alternate ways to begin this work. Our current system of care grant provides the theoretical framework and initial funding to build the beginning infrastructure for the Children's Mental Health Authority. However, we need a sustainable plan to position DCFS as the entity in Nevada that ensures children, youth, and families receive the best possible mental and behavioral health care so that they can achieve their goals. Thank you. That's all for me on DCFS, and I will turn it back over to Dr. Woodard to continue the presentation on behavioral health needs in Nevada.
Thank you, Dr. Freeman. So recognizing that we do have some time constraints today, you have been provided both the slides, but also I want to point your attention to some final slides on each of the presentations, which points you to some links to some additional resources that may be helpful if you wish to learn more about any of the topics that we've discussed here today. So now we're going to move to an overview of the state mental health system. Actually, we're going to be looking at the behavioral health in Nevada and the impacts of COVID-19. Next slide.
Apologize for delay.
That's okay. So important to recognize that COVID-19 as a pandemic is considered a disaster. When we have looking at how we can best estimate the impact of COVID-19 on behavioral health in Nevada and actually statewide and internationally, what we've had to do is look at an existing body of research that helps us to better understand what the impact of previous disasters have had on behavioral health. We recognize that anyone that experienced...
This is American Broadcast. Something happened and we are unable to see your screen share again. Can we try pulling it up one more time?
Are you able to see it now?
All right, we are good to go. You may begin.
Great, thank you. So as a disaster, COVID-19 has impacted virtually everyone in one way or another. Certainly individuals who have been most directly impacted may have the most adverse experiences when it comes to responding to COVID-19. But what we have done is we've looked at that body of literature related to disaster behavioral health to help us better conceptualize what we needed to address in the response and recovery efforts. Next slide. Most disasters have a very clear beginning, middle, and end. And when they do, there's a typical trajectory in which individuals will experience different types of stressors at different magnitudes throughout their response and recovery time periods. This is the best model that we have had in order to help to better anticipate what the impacts on behavioral health could be related to COVID. However, we recognize that there are some significant limitations to using this model. One of the primary limitations is that this model assumes that there is a very clear beginning, middle, and end to a disaster. And as we all know with COVID, it has had a very prolonged existence in Nevada, and the recovery is, although coming, relatively slow. We also recognize that the recovery from an impact such as a hurricane or a tornado tends to follow a normal trajectory where there is an opportunity for inventory and a community cleanup and engagement. However, in COVID, we have experienced something that is very different. Next slide. One of the best ways for us to conceptualize the impacts of COVID is to look at the stress continuum. And we recognize that there are different impacts depending on different degrees of stress. This includes individuals who are experiencing healthy amounts of stress, all the way to individuals who have experienced incredibly long, prolonged exposures to high degrees of stress. What we know from previous disasters is that individuals who were already experiencing high degrees of distress prior to the disaster are most likely to continue to experience moderate to severe levels of distress during and post the disaster. However, we also know that there are several impacts that a disaster can cause, such as economic uncertainty, housing instability, as well as grief from experience and bereavement that can also attribute to high levels of stressor. Depending on how long an individual is experiencing high degrees of stressors can impact how vulnerable they are to either having difficulty in coping or beginning to experience the onset of behavioral health conditions. Next slide. We were fortunate in Nevada to be eligible for what is called the Crisis Counseling Assistance and Training Program grant through FEMA and SAMHSA after the declaration of the emergency was approved in April. In order for us to formulate how we as a state were going to respond to the behavioral health needs in Nevada subsequent to COVID-19, we developed, along with FEMA and SAMHSA, this population exposure model. What this population exposure model does is it allows us to better understand what the potential impacts are for different populations that are impacted differently, including vulnerable populations, so that we could target our response and resource based on the level of exposure or the potential for significant distress due to COVID-19. Here we have prioritized at the very bottom those individuals who are bereaved or who have experienced a hospitalization, recognizing that both of those events could be incredibly difficult for someone to manage. We also have prioritized frontline health workers, especially knowing that we've been experiencing a considerable medical surge as of late. We see that frontline health workers, as well as emergency responders, have really been shouldering a lot of the burden related to the response to COVID. But we also recognize that it's not only those individuals who've been directly impacted, but also the secondary and tertiary impacts that COVID has had on individuals. This could also be loss of employment, students who have been disconnected from school, and other individuals in the community that have been responding to COVID-19. We have been able to respond in a number of different ways. So just some highlights from our response and recovery activities include training well over 700 people in psychological first aid. We've worked with the Nevada Hospital Association on engaging hospitals in crisis standards of care around behavioral health, crisis services, and emergency room diversion. We've worked to establish 24/7 psychiatric triage centers for children, adults, and adolescents to help to divert them from, with a mental or behavioral health crisis, to help to divert them from emergency rooms. We developed some programming and public service announcements, including our Home But Not Alone campaign, to really get the message out to help individuals understand where resources are available should they need them. Next slide. Starting in March of 2020, within DCFS and DPDH, we developed a behavioral health task force that began to look at some of the data that we had available to us to help us better understand what the immediate needs and impacts were so that we could develop our response strategies. Collectively, we authored the COVID-19 Behavioral Health Recovery Plan in May of 2020. And this plan really does span a number of different areas that we had identified as priority, with an emphasis on promotion, prevention, and early intervention. It also helped us to identify, should we receive additional federal funds, which we have, how we would plan to allocate that funding to address some of the highest needs. Next slide. The Crisis Counseling Assistance and Training Program that I had mentioned before was allowed through Nevada to develop the Nevada Resilience Project. The Nevada Resilience Project has allowed Nevada to hire a number of resilience ambassadors statewide, with a focus on intervening and providing promotion, prevention, and early intervention for individuals who are struggling with stressors as they relate to COVID-19. This helps us navigate them to needed resources, as well as to reduce stress and build on coping skills. We've worked with a number of community partners, including Washoe County Human Services Agency, the Boys and Girls Club of Truckee Meadows, Clark County Boys and Girls Club, and a number of other community organizations to ensure that our resilience ambassadors are available statewide when and where an individual needs additional support. With that, I'll hand it over to Dr. Freeman.
Thank you, Dr. Woodard. Dr. Megan Freeman for the record. I'm going to talk a little bit now about the state of youth mental health in terms of mental health needs before the pandemic and what some of the impacts of the pandemic have been. The State of Mental Health in America is an annual report produced by Mental Health America, a community-based nonprofit utilizing national survey data. As you can see here, Nevada typically does not fare well in the youth rankings. We've been 51st for the past 3 years. You will hear from Dr. Woodard in a few moments that the same is true for the overall rankings. On Monday, you also heard from Public and Behavioral Health Deputy Administrator Julia Peak that throughout public health more generally in Nevada, if there is a list that it's good to be at the top of, we tend to be at the bottom. In the youth section of the Mental Health America report, there are 7 indicators that make up these rankings. These indicators fall within the 4 general topic areas that you see listed here. Our biggest areas of difficulty are in access to care and prevalence of substance use among youth. These are very actionable concerns and that can be addressed with investments in screening, prevention, and early intervention. However, it will take resources and time to move the needle on these rankings. Next slide. The Youth Risk Behavior Surveillance System is a population level survey supported by the CDC and designed to monitor health risk behaviors, identify health disparities, and monitor the effectiveness of public health interventions. The most recent data were collected in 2019 by the University of Nevada, Reno. We do our own version of the survey here where we sample more widely than what the CDC does. And the data were collected at all regular public, charter, and alternative high schools and middle schools in Nevada. This slide draws attention to some of the most important behavioral health findings from the survey, including up to 2 in 5 youth struggling with significant feelings of depression, up to 1 in 5 youth having seriously considered suicide in the past year, and 1 in 5 youth engaging in self-harm. On this same survey, 50% of middle schoolers and 56% of high schoolers reported that they never or rarely got the kind of help they needed when they felt sad, empty, hopeless, angry, or anxious. And this data is consistent with our poor national rankings on access to care. Next slide. On slide 11, you will see the top 10 diagnoses most commonly associated with Medicaid billing for behavioral health for youth ages 0 to 18. These are 2019 numbers, so prior to the pandemic. For the sake of time, I will leave this for reference, but you will notice that mood and anxiety disorders are prominent. These are some of the risk factors and stressors that youth and families are coping with right now. I do want to emphasize that isolation and loneliness are associated with risk of future mental health problems, most commonly depression. However, while youth are reporting increased anxiety, depression, and stress right now, some teenagers are actually also reporting increased life satisfaction, which they say is because of more time for sleep, more time with family, and protection from some of the stressors of regular in-person life, like bullying. Next slide. One of the major concerns that has been well documented throughout the pandemic is a lack of adult eyes on children who would normally be interacting frequently with teachers, school staff, pediatricians, coaches, faith leaders, and in lots of other arenas. And we have seen a significant drop in calls to CPS from educational professionals in schools. However, over time, we've started to see more calls coming in from law enforcement and other professionals such as physicians. Total call numbers have returned to overall seasonal patterns at a slightly decreased rate compared to prior years. So this blue line here is the rate for 2020. I see this as an overall system success as our community has adjusted to the needs and current circumstances. Next slide. This graph shows calls to our Children's Mobile Crisis Response Hotline. You will notice the same general pattern as the CPS hotline calls, a large decrease at the onset of the pandemic, followed by a gradual return to regular seasonal patterns. For mobile crisis, the return to normal happened when children returned to school in the fall, and this actually caused a spike in need that has remained high since that time. This slide shows a change in the hospital diversion rate for mobile crisis. This is the number of youth stabilized safely in the community or diverted from psychiatric hospitalization. Initially, mobile crisis saw a decrease in hospital diversion, indicating that more youth were being hospitalized. And the program reports that this is due to youth with more serious levels of risk presenting for care and more difficulty placing natural community supports around the youth due to isolation and quarantine. I also want to make you aware of a national trend reported by the CDC in the fall. Although the overall number of pediatric visits to emergency departments decreased by about 70% during a lockdown and stay-at-home efforts, the proportion of visits that were related to behavioral health was 40 to 60% higher than normal during April through October. Most emergency departments lack the appropriate resources for providing behavioral health care, so we want to increase the availability of immediate and crisis care when and where youth and families need to access it. Finally, I would like to address the topic of youth suicide. On this chart, you were looking at the total number of suicides for ages 0 to 17 for 2010 to 2020 on the blue bars. The dotted line is the national suicide rate, which you can see has been increasing steadily over the past decade. The black line is Nevada's suicide rate, which has been fluctuating around the national rate. On Monday, you heard a little bit about public health surveillance from Public and Behavioral Health Deputy Administrator Julia Peak. She talked about how typically public health surveillance does not occur in real time, and youth suicide is the same. Although I know that this topic has been in the news and in all of our hearts recently, our 2020 numbers have not yet been finalized through the Office of Vital Statistics, so they could change from what you see here. It's too early to draw conclusions about how the pandemic has changed the youth suicide rates in Nevada or anywhere. What we do know so far about the impact of the pandemic on suicide in Nevada is that our 2020 total is not out of the realm of what is normal for Nevada over the past decade. I am a parent. One fatality is too many, and we strive for 0 suicides. But I would like to encourage us as a public health system not to focus on fatalities as the only important indicator of the burden of suicide in Nevada. That is why we are putting into place syndromic surveillance at hospitals and urgent care centers to better understand the full spectrum of help seeking for suicidal behavior. This is monitoring of the number of visits where a person presents with a suicide attempt. Additionally, we must continue to expand crisis services and provide outreach so that children, youth, families, and individuals who are suffering know where to go to get help. And with that, I'll turn this back over to Dr. Woodard. Thank you.
Thank you, Dr. Freeman. A little glimpse into the Mental Health America report, as Dr. Freeman had mentioned, this time specific to adults and mental health. This report comes out annually and uses a number of different metrics to look at the progress or a lack thereof that mental health services are having in specific states. Here you'll see a number of different rankings. Adults with any mental illness has continued to increase, where Nevada is about 20%, the United States average is 19%, and adults with a substance use disorder in the past year is at 9%, where the United States was at 7%. These data are from a study that was done in 2018. One of the issues that we have with these reports is because the data is so outdated, sometimes it's very difficult to attribute what it is that we're seeing in the data to what we're seeing in the state here and now. But we do use these as indicators to be able to measure progress as we look at this data year over year. I do also want to note that there have been some improvements in some of the areas related to adult mental health, including a reduction in adults expressing serious thoughts of suicide, adults with any mental illness who did not receive treatment. We actually have increased individuals who may have needed treatment and did receive treatment, as well as adults with cognitive disability who did not see a doctor due to costs. We've actually seen a good reduction in those numbers, which has enhanced our scores here. The reason that I think it's important to discuss these data is because far too often we do hear people use the shortcut that Nevada ranks 51st. But there are a lot of nuanced data points that go into that overall ranking. And so it's important to look in a more detailed fashion to understand what could possibly be driving some of our rankings. Next slide. As Dr. Freeman pointed out, the rate of suicide in Nevada in 2020, specific for youth, was not unusual compared to years past. And we actually see similar trends across all age groups, including adults and individuals age 65. Again, I do want to caution that these data are preliminary and not subject to change, or they are subject to change, sorry. We've also experienced an increase in opioid overdose deaths over the course of COVID. We actually had seen a relatively steady reduction over the last few years. And now we have seen actually the highest rate that we had in the past decade, with 484 fatalities in 2020. As I had noted before, there are a lot of reasons why this could be, not the least of which is increase in isolation and lack of access to care. We see also that we had a red alert back in November through the National Drug Helpline, which noted that Nevada had a 50% increase in overdose deaths between the first quarter and the second quarter of 2020. Much of this is also driven by non-COVID related issues, including the proliferation of synthetic opioids, including fentanyl. We've been seeing this troubling trend growing nationally, even pre-COVID, but we do realize that COVID could have had a significant impact in changing some of these numbers in Nevada. We've also seen an increase in ER utilization rates for individuals with suspected opioid-related emergency department encounters. We had a 26% increase in 2020, while the overall drug-related emergency department increased only 3%. So while we saw a 3% increase overall, 26%, the vast majority of that was related to opioid overdoses. Next slide. Some good news is that we are seeing an increase in utilization within Medicaid for substance use disorder. And we did actually see a pretty significant increase in 2020 for individuals in the Medicaid programming accessing substance use disorder treatment services. Next slide. We've been watching very closely a number of different indicators to help us better understand what is happening with traditional behavioral health service utilization. And we have not seen a very significant increase in overall utilization during COVID-19. There are a number of different reasons for this, not the least of which is we did have a substantial time period where we had stay-at-home orders, and we know that individuals have been avoiding care. We also know that following disasters, we typically see an increase in need for traditional behavioral health services between 12 and 18 months following the anniversary of the occurrence of the disaster. So we anticipate that we can see increased needs for services moving forward following March of 2021. That being said, we have seen an increase in crisis services. We've seen a 170% increase in calls to the warm line, and increases in both acuity and the length of calls have increased for our lifeline for crisis support services of Nevada. Through the Nevada Resilience Project, which is that promotion and prevention and early intervention, we've been able to serve almost 73,000 individuals statewide since June. And our COVID ER grant recipients who are providing crisis triage and inpatient services have seen approximately a 100% increase year over year in individuals looking to access care. Again, we continue to watch and monitor to see what the impact could be on overall traditional behavioral health services. And currently, we have not seen a significant increase. Where we have seen some nice change is in telehealth. So telehealth utilization for behavioral health services actually helped, I think, with a lot of continuity of care for individuals who had previously been engaged in behavioral health services. But we also saw a marked increase of individuals who initiated treatment services utilizing telehealth. Pre-COVID, approximately 24% of individuals had had their initial visit via telehealth, and that moved to 41% of initial visits the 6 months following March of 2020. There's certainly a lot of work to do in the road ahead. We have to recognize that there is a risk for increased and severe distress as it relates to our economic recovery. And the more prolonged this recovery is, the more likely that individuals will continue to experience distress. Recognize risk for increased suffering among children and parents and caregivers due to isolation, loneliness, and stress due to school closures as they persist. Address the needs for individuals who are struggling to cope and manage with new or ongoing stressors, and recognizing the opportunities for prevention and early intervention as recovery continues. Some of our priorities are to prioritize basic systems that help to keep people safe and secure, focusing on social determinants of health, such as economic factors, food security, housing stability, access to healthcare, and access to education. Increased capacity to provide school-based behavioral health care for children, continued efforts to promote, prevent, and intervene early when individuals are having a difficulty coping, providing crisis services for individuals and families when and where they need them, to include suicide prevention, and continued efforts to build community resilience and family resilience. And with that, Chair, I think Dr. Freeman and I will take questions if time allows.
You guys did an amazing job of compacting them. I know I asked you a lot to try to, consolidate everything that's going on, especially recently in this mental health field and, everything. So I appreciate you guys doing that. We do have a couple of questions, and I will start with Vice Chair Peters.
Thank you, Chair. And I echo what the chair has said about doing an awesome job getting all of that information to us in such a shortened period of time. Now, I have a follow-up question related to your data. Thank you so much for presenting all of that. It's really important to ensure that we're getting policies to where and when families and children need it. But I'm just wondering what data gaps you guys can identify or have identified for ensuring that we have all the information we need to develop response policies to ensure that we're getting those resources to children and families when and where they need it.
Dr. Freeman, for the record, thank you for the question through you, Chair Wynn, to Vice Chair Peters.
Oh, feel free to go directly to the member.
Oh, thank you, Chair. That's a fantastic question. And we, one of the amazing things about Nevada is that we actually are collecting a ton of data on children, which is wonderful. We have data from our Children's Mobile Crisis Team. We get a lot of data through the school. There's a couple of different initiatives on collecting data through the schools. Right now, I think where we need to focus our efforts is on suicide prevention. And I mentioned this briefly during the presentation. We would like to be getting more real-time information from hospital emergency departments and urgent cares on individuals across the lifespan who are presenting for suicidal behaviors, because that will help us understand in more recent or more real time what the needs are and who is having the need, where we need to focus our prevention efforts. Dr. Woodard, I don't know if you want to add anything to that.
No, that was great. Thank you.
Vice Chair Peters, do you have any follow-up?
Just a comment that's great to hear. I've been working with Dr. Woodard on a bill that I hope will help allow us to fill that data gap in particular. So thank you again.
And if we can go next to Assemblywoman Titus.
Thank you, Madam Chair. I appreciate the opportunity to ask a question, and I appreciate both of you Dr. Woodard and Dr. Freeman being on this call today. And I know that it was a lot of information in a short amount of time. Couple questions on slides number 8 and slide number 18. Nevada continues to be the 51st and all of those data points at the worst of the worst, as you pointed out. And this is my 4th session. I've seen these presentations every session because I've been on health and human services each time. We're not moving that needle at all. And each time I have, when we hear these presentations, we talk about collecting data. And at some point we have to make some changes, because I'd love to see, before I'm termed out wherever, some of those needles moving, that some of that's improvement. And I haven't heard really anything more than you're collecting more data, not really any solutions. And so what I want to know is, has the number of childhood behavior specialists increased? And what are we doing about reaching out and educating folks so that they can have more, so we can have more providers, so there's more access to care. And I know we have more Medicaid recipients signed up, but that doesn't mean that having signed up to Medicaid doesn't mean you have better access to care. So I have huge concerns about that. And I'd like to see at some point after this is over, you may not have that today and we're limited for time. I'd like to see the number of providers that you have available in your system, what we're doing to outreach, whether we're using some reciprocity to get these people licensed so we can have more access. That's my first question. I want to know what you're doing for the specialists that these people see. Second question is at telehealth data. You said we've increased the use of telehealth from 24% to 41%, but that doesn't mean there's actually been increased access to care. It means they maybe weren't able to get in the office, maybe that they weren't otherwise going to see that provider unless they had the telehealth. So I don't know that that's actually a more percentage of access and actually real visits. So I'd like to see some data on that and what we're actually doing to have folks get that access to care, because that's, at the end of the day, follow-up access to care, getting in treatment programs, having those specialists available for these adults and children. I think that's really when we're going to start solving some problems. So perhaps you can get us some more information on the actual providers. Thank you.
This is Dr. Freeman. For the record, thank you for the question, Assemblywoman Titus, and I will just very briefly touch on your question, and then I think that it's best for me to take this back to our division leadership and we can submit some more information to you in writing. But one thing I will just point out is that the Mental Health America reports in any given year are based on data that was collected 3 years prior. So it is very possible that we have made strides in the past 3 years that won't be reflected until we see the rankings on future years reports. We have been working to expand our system of care in Nevada. I think that's very significant for children. And we just may not be seeing those numbers reflected yet in the report. However, we will submit a response to you in writing on your questions regarding providers and the other aspects of your question, if that's all right.
Great, thank you. Because I don't think there's a person on this call, yourselves included, that doesn't want to see Nevada rise out of that 51st ranking in so many things. And so thank you for that. And I appreciate all you're doing. Don't get me wrong. These are just a tough list. So thank you.
Thank you. And I know we have several other questions, but I'm just going to do one more that's in the queue. If we can turn to Assemblywoman Summers Armstrong.
Thank you, Chair Wynn. Thank you so much for your presentation, Dr. Freeman. Assemblywoman Titus picked up on one of my questions, but I'd like to just expand with a follow-up question, which would be, is your department partnering with any national organizations or nonprofits to help with addressing some of the mental health issues throughout the state? Meaning, for instance, do you have any nonprofit organizations that are certified that are able to go into the schools and give presentations to kids, or do community outreach, so that the message that there is help, that there are resources out there so that people know more about it? And I can just tell you that I'm seeing here in Southern Nevada a lot more discussion, open, frank discussion about mental health. And I think that if we had the more support we can have for those conversations from your department, the better I think that we can reach people in our community. So thank you.
This is Dr. Freeman for the record, and thank you so much for your comments. We would love to partner with you to understand more about what you are seeing, and we can absolutely get you a list of our community partners and national partners that provide us with technical assistance. We do seek a lot of support and technical assistance, but there is always room for improvement. So would love to have that conversation with you.
Thank you. And if there's any other documentation that you guys have, if you could provide it to our policy analyst, Patrick, he can distribute it to all of the members. And I would encourage everyone to reach out to them. I believe we have their contact information that we've provided to you all to follow up with any additional offline conversations about more detailed discussions about what we can do in our state. But with that, thank you guys so much for presenting, and you're welcome to stay on, or we are just going to move to our next presentation. So we are moving on to our regional behavioral health policy boards. And if I didn't ask the last presenters to pare down what they do and what their roles are and what they are doing in our state and for our communities, I have asked probably the impossible of these next individuals. I have asked them to kind of briefly introduce themselves, give us a 5-minute presentation each. I know we still have those 2 bills, but I do think it's really important for us to hear from them. And so we are going to start with these regional behavioral health policy boards. And I will start with probably, I will welcome and ask you to introduce yourself, Ms. Valerie Haskin, the Rural Regional Behavioral Health Coordinator.
Thank you so much. I greatly appreciate it. Good afternoon, Madam Chair and members of the committee. Hold on just a second while I get my presentation up here. We had initially planned to go in order of our alphabetical order. So here we go. So for the record, again, my name is Valerie Kwape Haskin, Rural Regional Behavioral Health Coordinator. Today, I'll be giving a brief introduction to the Rural Regional Behavioral Health Policy Board. There is a handout in your packet that accompanies this presentation, which gives far more detail about the board than I'm able to present to you today. The Rural Regional Behavioral Health Policy Board represents a 6-county region in northeastern Nevada, which includes Elko, Eureka, Humboldt, Lander. Can you see my video? Okay, sorry about that. Hi. Humboldt, Lander, Pershing, and White Pine counties. The combined area of this region is slightly larger than the state of Mississippi, and the population sits just under 100,000. Let's see if I can. So this large expansive space covered by the region and the geographic distance to specialty services influences a lot of our board's priorities. The priorities seen here were designated by the board in early 2020 and will be revised and updated at the board's next meeting on February 24th. One of the major issues community members in our region face is transportation, both to and from behavioral health services. This is the case for both crisis and non-crisis services. While a person in crisis may be able to get emergency transportation to in-person services in Reno, Carson, or Las Vegas, our stakeholders have alerted us to many persons being released from emergency care without direct transportation home. In this case, they may be stuck in the city where they were released, or sometimes they're put on public transportation for the return home, often without medication, food, or water, and due to multiple connections, this may take more than one day. Additionally, the lion's share of the persons in our region seeking behavioral health care services are either covered or are eligible for Medicaid. Thus, previous to the COVID-19 pandemic, it was a priority of the board to seek and maintain seek improved Medicaid reimbursement for behavioral health services to ensure that providers could maintain service levels to meet their needs. Over the last year, that conversation has changed due to budgetary cuts and concerns to preserving the Medicaid services that are currently available. While most of the state can be considered healthcare service shortage areas, the issue is exacerbated in our most frontier communities and is often even worse in regards to behavioral health services. The board has prioritized seeking ways to improve the ability of local organizations to recruit behavioral health providers, including improving PASTA licensure for those who are moving to Nevada from out of state. This is addressed in the board's bill this legislative session, SB 44. While state and local partners have made great strides in improving data quality and communication, this is still a persistent issue within our region. Assisting our local stakeholders in improving the quality and accuracy of the data collected at the local level and how it is communicated with the state and other regional stakeholders is another priority of the board. The board has sought to increase its visibility in an attempt to better engage local, regional, and state stakeholders and increase communication regarding current resources and challenges. The board prioritizes supporting programs that consider the needs of youth, elders, and families in a holistic approach, as issues within family units do not frequently happen in a vacuum, and addressing the issue throughout the family circuit may have improved outcomes. Last but not least, the Nevada Department of Veterans Services has made it known to us that our region has a comparatively high percentage of veterans within our population. The board prioritizes efforts that improve the quality and access to services for those who have served our nation in the armed forces. While many communities in our region may be geographically isolated, they were not unaffected by the COVID-19 pandemic. The information I'm discussing here has been shared in community stakeholder meetings. It should be cautioned that many local organizations involved are focusing their limited resources on response, so data available may not currently reflect these concerns. Hopefully, they will be able to catch up as pressure from the COVID response subsides. Also, please remember that in such small communities, large increases may constitute small numbers in comparison to urban communities. However, with already thin behavioral health services available, it does not take much to overwhelm local resources. So early on, our local hospitals saw an increase in the number of persons presenting to the emergency departments in crisis. While some of these community members had presented to local hospitals in crisis before, most of them were experiencing a mental health crisis for their first time. This was followed by a sort of second wave of problems where hospitals were seeing more patients who were presenting for reasons related to increased alcohol and substance use, as well as increased intentional overdoses. Our local stakeholders have reported major concerns regarding increases in depression and anxiety among youth, as well as frontline workers such as healthcare, law enforcement, and other emergency health services. Additionally, increased isolation among community members is a major concern, but even more so for those who are homebound or who are more geographically isolated. And that is my very, very brief introduction to the Rural Regional Behavioral Health Policy Board. Thank you so much for your time. If you have any further questions or comments, I can be reached best via email.
Thank you, Ms. Haskin. I appreciate your brevity. I know that this is a complex subject, and so I appreciate that. And I'm just going to move on, I'm sorry, to Ms. Dorothy Edwards. I don't know if this is the order you were told, but this is the order I have, and she is with the Washoe County Regional Behavioral Health Coordinator.
And don't start my 5 minutes till Valerie gets our slide up.
I'll wait until you're ready.
Okay. And I just have the one slide, so you can start the timer now. So good afternoon, Madam Chair and members of the committee. I'm Dorothy Edwards, the Washoe Regional Behavioral Health Coordinator, and I also will share just a few of the main priorities and action strategies and some challenges that the Washoe Behavioral Health Policy Board has identified for Washoe County and as it expanded throughout Washoe County. So I'll follow the items on this slide, I believe in that order. In response, support and analysis of where Washoe County is in terms of readiness to stand up a crisis stabilization center remains something on which the board is focused. In response to the ongoing issues of individuals experiencing a behavioral health crisis and often being taken to jail or emergency rooms inappropriately, these facilities are considered an emergency health care alternative. The strategy for success for this state-supported endeavor began in the 80th legislative session with the introduction and passage of Assembly Bill 66, which addressed some components of this type of facility. During this biennium, our strategy for moving forward includes the completion of an assets and gaps analysis, a visit to one of the originators of the concept in Arizona, and increased collaboration with partners, including our state, city, and county leadership, to discuss the next steps. While Washoe remains well poised in some required elements, challenges to success, including finding sustained funding, some infrastructure, and then developing the policies and processes required for collaboration between agencies. It does remain a strong priority in our county. Equitable focus on substance misuse. So while we know behavioral health encompasses mental health and substance misuse, there has been some concern expressed that the focus of programs, funding, and policy might be inequitable between the two. Understanding that the two are often co-occurring, we need to work to ensure inclusion and collaboration of all sectors of behavioral health. Strategy for success here began as we invited presenters from all sides of behavioral health, including substance misuse treatment, prevention, and recovery, to provide information, education through a bill draft. Several of those were selected for the board's current bill, Senate Bill 69. Our work and focus will include supporting the development of a diverse, culturally appropriate, inclusive, and well-trained workforce in both areas of behavioral health. Behavioral health response during, before, and after a crisis, as Dr. Woodard talked about. If we learned anything from this public health crisis, it's that we need a robust plan and trained staff who can cope with these sometimes overwhelming behavioral health consequences of an emergent event. Our strategy in Washoe for ongoing success included participating in the Resilience Project. Another strategy was the development this year of a draft behavioral health annex to our regional emergency response plan. We'll continue to encourage and reach out to all organizations from our board and within the community to take advantage of resources for training such as psychological first aid, with the goal to create community response teams to activate when needed during an event. We look forward to conducting drills and exercises with local and state partners when it's safe and practical to do so. The CHIP, the Community Health Improvement Plan. The CHIP is actually developed by Washoe County Health District. It's a plan of action to address local conditions that are contributing or causing poor health in Washoe County. Behavioral health was seen as a top concern cited by the community, and one that greatly suffers from lack of adequate resources and available workforce. It also ties in closely to the housing focus area, as many chronically homeless individuals suffer from mental illness and substance use disorders, and adequate housing is seen as a critical foundation to providing successful treatment. The Washoe Board committed its support of the behavioral health focus areas within the CHIP, and that'll include some robust and improved data collection and analysis, support, and participation by some in the Build for Zero Homeless Initiative, which is being implemented by Washoe County. Challenges, no surprise, include the lack of housing and resources, along with a trained workforce and more workforce. Finally, regional behavioral health data. As we've all talked about today, the board understands that accurate data around behavioral health is necessary to inform trends and assist making decisions. The annual Washoe Behavioral Health Profile is nearing completion, as is the Policy Board Annual Report, which will both include the most recent behavioral health data available for state and regional comparisons. A data website or dashboard is required for the regions, and Washoe continues to work on theirs with a target completion date of this year. As Val said, I am happy to provide additional information on any of these subjects. I'll make sure that you get the copies of the reports I addressed. So please feel free to reach out to me separately, and we can get you what you need to know. Thank you so much.
Thank you so much, Dorothy and Ms. Edwards. And we will move next to the Clark Regional Behavioral Health Coordinator, Ms. Teresa. And do you say, is it Etchberry? Did I say that correctly?
Yes, you did. Thank you.
Wonderful. Thank you.
Good afternoon, Chair Wynn and Vice Chair Peters and committee members, and the opportunity to speak today. This is my first time, so I might be a little nervous. We are the Clark Regional Behavioral Health Coordinator. This is the board. Clark County is one of the largest counties in Nevada. Just to give you a brief overview, per our Nevada State Demographer and the Census Bureau, the population in 2019 for Clark County was 2,255,175 persons. Clark County holds 73.6% of Nevada's population. So we have a very diverse, next screen please, Valerie, thank you. We have a very diverse board members. They are well-versed in behavioral health issues, and they hold different positions throughout the county and other boards. And they also share our demographics for our board and for our county. Next slide, please. The Clark County Behavioral Health Board embraces a data-driven approach to identify the behavioral health outcomes and system gaps of the region. Therefore, the success of the data depends on the existence of data, the types of data, and the quality of data gathered. So particularly what we are looking for in our data to look for the gaps and challenges in our area are our civil commitments. Next slide, please. As our civil commitments to details on law enforcement, transportation to emergency medical services, hospital emergency rooms, and the course of treatment in the emergency rooms, and a summary of any transition to psychiatric services. We also would like to know where people are placed and discharged and the length of stay for those hospitalized and treated in emergency rooms. This will guide the board to assess the after and ongoing care and for the different reports that we have to produce to our stakeholders and also to our state. Workforce development is another concern. We would like to have an increase in the supply of our providers in behavioral health. The board recognizes that the workforce and the availability of qualified behavioral health providers are a concern here in Clark County. While the region has seen a steady growth, our community still falls below the average of providers per capita. The board wants to further investigate what measures the board can take to improve the behavioral health workforce supply in Clark County. The data management and application, we are working on a data dashboard, but we also need to have a data management system for Clark County, such as a health information exchange to provide access to behavioral health data and for the ease of use for providers and for residents of Clark County. Also, the other is the big, the thing that happened in 2020 is the pandemic crisis. And we have seen an increase in the number of people seeking services, and on a national level, and as well as Nevada, and what was stated in Dr. Woodard's and Dr. Freeman's presentations is that we have an increasing number of adults, youth, and children reporting symptoms of anxiety, depression, and an increase in the number of suicides. We are also seeing the disproportionate impacts on Blacks, Indigenous, and people of color population, including the elderly, individuals with developmental disabilities, residents of rural communities, and people living in poverty. Next slide. These concerns and challenges drives the board's priorities, and we would like to see the data for, oh, sorry, Valerie, can you go back to one slide over, just the priorities, thank you. So as I spoke about the priorities for the mental health and workforce development, we also want to see dedicated funding for crisis services. We spent many weeks working on a Crisis Now, gathering information, talking about a Crisis Now system. We would like to expand our mobile crisis teams, that it will happen all over the county, because we have a large urban area, but we also have many rural areas that lack crisis teams. The board also wants to increase community access to crisis intervention, and we also want to increase the stabilization of crisis services when for aftercare and ongoing services.
Excuse me, Ms. Etchberry. We are unable to see your screen share. I'm going to stop it and then have you bring it back up again.
Okay. Valerie, are you doing that or do you need me to do it? Can you
know
set
what?
it down?
I think all the members can see it. I don't know if the public is not able to see it.
Yes, we were just
America.
having some issues taking it to broadcast, and we can see it now. Thank you so much. You may continue.
And Ms. Exbury, can I have you wrap up too? You're already at your 5 minutes.
Oh, okay. So thank you. The board recognizes the behavioral health in our community, and we must recognize the use of substance use and mental health and the use of telehealth services. Thank you.
Thank you. You did a great job presenting for your first time. I would have never known.
Thanks.
And finally, can we go to Ms. Jessica Flood with the Northern Regional Behavioral, she is the Northern Regional Behavioral Health Coordinator. These are long titles.
Yeah. Thank you. All right, so I'm Jessica Flood, Regional Behavioral Health Coordinator for the Northern Region, which is Carson, Lyon, Douglas, Churchill, and Story counties. Next slide. I have an overview of the regions and I've circled my own region, but that gives you guys an idea of where they lie. Next slide. These are the members on the board. If you're interested, of note, the chair is Taylor Allison, Executive Director of Partnership Douglas County, and the vice chair is Dr. Ali Bannister, Carson City Juvenile Protection Office. Next slide. So our board priorities have remained pretty stable over the last 5 years. By far, the top priority is obtaining sustainable funding for current crisis stabilization and jail diversion programs. We have our mobile outreach safety team, which is a co-responder team. Our FAST teams are jail reentry. CIT is crisis intervention training for law enforcement, mental health training. And then our Mallory Crisis Center is run through Carson Tahoe, and it's our psychiatric ER. The second priority is increasing behavioral health workforce with the capability to treat adults and youth, increasing access to treatment in all levels of care, increasing access to affordable and supportive housing, and developing services to support continuity of care. And that's kind of looking at wraparound and community health workers. Next slide. So I know that we're talking about priorities and gaps, but to Assemblywoman Titus's point, we have seen some progress in our region, and it's pretty exciting. I spoke about Mallory Crisis Center. That's been really pivotal to have that 24/7 access for people in crisis. We're also really lucky to have CCBHCs, Certified Community Behavioral Health Centers. And both Carson Tahoe and the CCBHCs have assertive community treatment teams, which really provide this wraparound to people that are in serious mental illness. Those programs, along with our mobile outreach safety teams, we're seeing this incredible ability to identify individuals in crisis, really get them into treatment and stabilized in a way that we haven't seen before. So I was just talking to the MOST officer in Carson City yesterday, and he was saying that there's individuals that have been in crisis for 10 years who are now stable. And then, Dr. Woodard was talking about their emphasis in making jail reentry and criminal justice diversion evidence-based. The state has done a ton of work with us to really bring our jail reentry teams up to evidence-based practice, and we have a lot of gratitude for that. So we think that we're making progress in developing this comprehensive mental health system bit by bit. Next slide. What we think is working in our region is that we have these local behavioral health task forces that really provide community input into the Northern Board. And we also have a culture of collaboration in the Northern region with a lot of organizations partnering on grants. And again, I just have to give a lot of credit to the state. We've been able to really identify community partners that are willing to expand their treatment services. And the state's been able to bring down some funding for those programs. And along with that, the state provides quite a bit of technical assistance that have allowed our programs to hopefully achieve sustainability in the future. Next slide. So our gaps and needs mirror our priorities. We need access to care for youth and adults, especially youth. I've had calls from parents who have insurance and despite their best efforts cannot find treatment for youth coming out of inpatient psychiatric hospitalization. We need more behavioral health workforce. It's really inhibiting us from creating more programs and expanding access to care. We are rich in crisis lines and we appreciate many of them, but we've noticed that we still need in-person outreach for people that are in crisis, and that's in the youth perspective and the adult. In our region, we really see a gap for supported housing, including group homes and long-term supported living arrangements for people with serious mental illness. And as Valerie touched on, we really see this need for support for COVID-induced risk factors. So isolation, unemployment, and grief and loss, in particular, seniors. We're seeing a lot of seniors and older adults that are in crisis and are starting to need hospitalization due to the isolation. Next slide. So next steps, as Dorothy was saying and Dr. Woodard, we're working on regional behavioral health emergency operations planning. Like Dorothy was saying, we're trying to develop that website that's in NRS for the boards to have that shows that data dashboard. And then I think our region is trying to educate ourselves about what regional behavioral health authorities would look like, really is taking that next step to regionalize mental health through these boards. And that's because with these multi-county arrangements, we find that we don't have any central way of applying for grants or bringing funding down into the region. So I think there's a lot of benefits in looking in that formalization. Next slide. So that's it. If you have any questions, I'm available, but I really appreciate your time.
Thank you so much. And at this time, I'm actually not going to take any questions, but I would encourage all of my members. I know that prior to my participation last session on HHS, I wasn't aware of all these policy boards that exist in our state, and they really are a resource of things that are happening regionally in your districts. So I would really highly encourage you to reach out to them. You can find the ones that are appropriate for your area of the state and reach out to them to see what they are doing, because they are really boots on the ground. They have a better idea of what's going on locally and can kind of give you that information, especially if you're looking at crafting legislation in the future in these areas. So with that, I would thank everyone for presenting and keeping it very brief. And I'm glad that we were able to introduce you all to our members. So thank you. I'm going to jump right into the hearings right now. Committee members and members of the public, this is obviously my first time being a chair of any committee, and I'm not a technology person. And since my 10-year-old son is not here to guide me through the process, I really do appreciate everyone's patience with me, as I am the first to admit I do not know everything. I am not perfect, and I'm always learning, and so I'm always open to suggestions as we go through this. The things that are very important to me are fairness, transparency, equity. I think those are key to this process, working fairly, and especially in this new virtual meeting format. And I will do everything that I can to uphold these traditional and constitutional values. So that's kind of my commitment going into these first hearings. I'm excited. We have 2 legislative measures being presented this afternoon, and I have allocated equal time and testimony in support, opposition, and neutral for each bill after its introduction. And to be specific, each person providing testimony in support or opposition will be a maximum of 2 minutes, and I'll have staff timing them as well, just to make sure that everyone is given a fair opportunity to speak. And we will limit the overall presentation of testimony in support, opposition, and neutral to 20 minutes apiece. I don't actually anticipate that we will need that kind of time, but I do want to set those out so we have that. All the testimony and support and neutral will be over the audio line to ensure fairness for all the testifiers at this time. And anyone joining the meeting on camera is either a committee member, staff, bill sponsor, or presenter, and certain staff from agencies to help respond to any questions that we may have from committee members throughout this hearing. But at this time, no one is going to be joining the meeting on camera right now. I am open to changing this policy to make sure that we are as open and as transparent as we possibly can to engage as many of the public members that want to appear in that new format. And I'm working with broadcast services as well as all of you to make sure that we are able to do that fairly. So with that, I'm going to open up the hearing on Assembly Bill 62. This bill relates to provisions related to the Nevada ABLE Savings Program, and hopefully you all had an opportunity to review some of the legislation from the 2019 session in the links that we provided to you on Monday. And with that, we have State Treasurer Zach Conine and Senior Policy Director Eric Jimenez here to introduce themselves and introduce their bill. And so you guys can begin when you are ready.
Thank you, Chair Wynn and members of the committee. For the record, I'm Zach Conine, and I have the pleasure of serving as your Nevada State Treasurer. I'm very excited to be here today to present Assembly Bill 62, which helps to innovate and strengthen Nevada's ABLE savings programs to ensure that Nevadans with disabilities have the opportunity to save for a better future. Broadly speaking, ABLE accounts are tax-advantaged savings accounts that allow people with disabilities to earn and save money without losing access to vital programs like Medicaid and Social Security. By making these tax-free savings accounts available to individuals to cover qualified disability-related expenses for things like education, housing, and transportation, the program aims to ease the financial burden faced by citizens with disabilities who are the most underemployed demographic group in the state. In the 2019 legislative session, our office worked with Assemblywoman Cohen and the Division of Aging and Disability Services to pass AB 130, which moved the entire ABLE savings program into the Treasurer's office. Since that time, our office has worked with hundreds of Nevadans with disabilities and their families to make sure they can gain access to these accounts without any impact or cost to the state's general fund. The provisions of AB 62 would make Nevada the first state in the country to find innovative ways to incentivize people with disabilities to open these accounts and build up account balances to build their own great, big, beautiful tomorrow. I'll now pass it over to Eric Jimenez in our office to walk through the committee, through the specifics of the bill, and I'm happy to answer any questions that the committee may have. Before I do that, let me just take a moment to mention the absolutely tremendous work Eric has done focusing on the ABLE program over the last 2 years. His singular effort has helped hundreds of Nevada families, and he did that while helping me coordinate the largest recovery effort in the state's history. Eric?
Thank you, Mr. Treasurer and Madam Chair, members of the committee. Eric Jimenez with the Treasurer's Office for the record. I think it's important when we talk about ABLE accounts to understand that the passage of the ABLE Act was the single greatest kind of move towards disability independence since the Americans with Disabilities Act. And when we took over the program from Aging and Disability Services in 2019, we had a little over 200 accounts with about $1 million in assets. We've grown that to over 1,000 accounts with $6 million in assets, all using $0 from our state general fund. So we do this for free. We do this out of the goodness of our hearts. And it's not in the state's interest to make money on these accounts. We do it so people with disabilities can save and really just get out of bad situations and build a brighter future. So broadly speaking, we have a very, very simple bill in front of you today. And I'd be remiss if I didn't thank Carly O'Krent from LCB for working with us to kind of get this really tight. And I think it'll help a lot of folks. But what this bill does is it kind of modernizes our ABLE accounts to after our college kickstart program, which is something that we do in the Treasurer's Office, which gives $50 to every kindergartner in Nevada, so we can kind of kickstart those savings. One of the biggest barriers when I talk to families about the benefits of ABLE accounts, they say, well, it's great. I would love to start saving. You know, I'd love to start earning an income without losing my Medicaid and my Social Security benefits, but I don't have the startup capital to open a bank account. So what we're thinking here is how can we find some innovative ways to pay for seeding accounts to grow these accounts in a way that makes it more sustainable for the state going forward. So the idea here is the bill would authorize our office to promulgate regulations that would incentivize the opening of new accounts, similar to how we already do it with College Kickstart, and then to incentivize regular deposits from existing account holders. So if I have an ABLE account and I want to start contributing $100 a month, how can the state kind of meet them halfway and start to figure out how they can match some of those contributions? All of this we are proposing to be funded not out of the general fund, no tax dollars for this program, and would be done purely through private philanthropy and federal grant funding. And I want to say thank you to some of the groups that have already expressed interest in doing that, particularly the Nevada Bankers Association. They've been a great partner in making sure that we get awareness about these accounts out to the public. Other than that, that's pretty much the bill in a nutshell, and I'm happy to take any questions from the committee.
Thank you. Do we have any questions here? I didn't get any in the chat here, but if you can just raise your hand or wave. I see Assemblywoman Gorlow, and you can feel free to go directly to the Assembly member to address your questions or answers.
Thank you very much, Chair. I just had a quick question, one a little bit of elaboration on what is actually considered a qualifying disability.
Thank you, Assemblywoman. It's always good to see you. Erica Menace for the record. I'm happy to go over that if you give me a second. So a qualified disability expense is any expense that is occurred as a result of living with a disability and is intended to improve someone's quality of life. And I think it's important here, when the bill was passed and signed by President Obama, the idea was, how can we make these categories as flexible as possible so we can encourage people to save, but really allow them to use these expenses for pretty much anything that they would encounter. So those vary from education, health and wellness, housing, transportation, legal and professional fees, financial management, employment training and support, assistive technology, and personal support services. And I think just to kind of top it off, Assemblywoman, I get asked a question when I talk to families a lot, could I open an ABLE account and use that money to take a trip to Disneyland? And I think it's important that we're trying to make an argument that says, if that improves your quality of life and gives you better mental health or something like that, then I could make an argument that that would be an eligible expense. So the goal here is to make it as broad as possible, so these folks can spend this money just like everyone else would with their checking account.
Thank you very much. And I apologize, my question, that actually I was curious about that as well. But my question was more to who qualifies, what disabilities would qualify?
Erica Menace for the record. So there's a very thick Social Security guidance. It's called the Social Security Blue Book. But people with significant disabilities that occur prior to the age of 26 are eligible for an ABLE account. In terms of disabilities that would qualify, any of your IDD or your intellectual developmental disabilities, autism, Down syndrome, those sorts of things, as well as we work with the Nevada Justice Association on this too, on making sure that people with mental health disorders also can qualify for these accounts. So the way we talk to families is, if you have a question, just ask, but most disabilities are covered under the ABLE Act.
Thank you very much for that clarification.
And I think we have a question from Assemblywoman Benitez Thompson.
Thank you so much. I appreciate the opportunity to ask a question, Chair. So well, first of all, thank you so much for all the work that you've done on the ABLE program. Thank you for giving it a great home and a place for it to live last session, where it would get lots of TLC. So I guess I wanted to ask about the, in section 1, your 4 sub 3, the methods and incentives to encourage contributions to a saving trust account. And could you tell us more about what we might expect to see when we talk about incentives?
Yes, and Erica Menace for the record. Assemblywoman, we wanted to be very deliberate in this, insofar as that we don't know how much money we'll be able to bring in either from federal grants or private dollars. We didn't want to commit in statute to a particular dollar figure if we couldn't meet that dollar figure. So the idea will be over the next few months, assuming this bill works its way through the process, we can go secure some funding and then outline what that minimum threshold would be. And I think at this point, we're looking in the realm of maybe $50 to $100. And we would define that clearly through regulations that would go through the Legislative Commission. But at this point in time, we wanted to give ourselves the flexibility if that dollar number kind of moves around a little bit.
If I could ask a follow-up, Madam Chair?
Yes, go ahead.
Thanks so much. So I guess then, should I be expecting, I hear you talk about a minimum amount. So I guess my assumption then is that the incentive would be a cash incentive for opening account, perhaps something akin to like the Kickstart program. Is that what I should hold as kind of a frame of reference?
I think that's exactly right, Assemblywoman Eric Jimenez, for the record. I also think that, we're continually working through this process, and I want to make sure that we clarify in the regulations, our ABLE account program is open to anyone in the country if they wanted to open an account. I think it would be important, just to clarify this for the record, that Nevada participants in this program would be eligible for the incentives. While I appreciate people from Virginia and South Carolina participating in our program, I think our goal here is to try to help as many Nevadans as we can.
And Treasurer Conan, for the record, that would match some of the work we do on the college savings front, where there are matching programs available for individuals within Nevada, even though the programs are available broadly for everyone.
Thank you. And do we have any other questions here? I didn't get any other messages. I just have one comment, or maybe you can highlight it. I know that when we had spoke about this bill, you had talked about how this isn't been enacted anywhere else. So this would kind of be a unique, innovative program that other people around the country would be looking at Nevada as like a model in this area. Can you speak on that?
Yeah, thank you, Madam Chair. Eric Jimenez, for the record. I think this point is why we wanted to bring this bill forward to get, make it abundantly clear that the legislative intent was kind of to move forward with a program like this. We would be the first program in the country to do something like this, assuming we're able to secure funding. And we're part of an alliance of states that administer ABLE accounts, about 20 of them. There's about 45 nationally that administer them. I talk to most of them on a monthly basis. I would say that the state of California, the state of Oregon are anxiously watching this bill to see if we're successful, and they would love to replicate that. Additionally, we've been in some conversations with the Senate Committee on Aging, the U.S. Senate Committee on Aging, and the chairman there from Pennsylvania, and they are also watching this to see if it's successful, if they could replicate this on a federal level to do some sort of block grant into ABLE accounts to make sure that we incentivize that growth.
Thank you so much. And I don't see any other questions from members. I'm looking here. Nope, I don't see any. Oh, did someone say something?
It's Assemblywoman Benitez Thompson. I just did have a follow-up kind of on the endowment and distribution part, but I didn't want to ask like 3 questions in a row. So I thought I'd take a pause.
It's okay, Assemblywoman, go ahead.
Thanks so much. So, because I do see here that that you're going to develop the methods and incentives to encourage contributions to the saving trust fund, trust accounts, but that there's also going to be an endowment piece. So I imagine that once you are successful, which we know you will be, in getting grants into that main endowment, can you talk a little bit about what that procedure will look like in terms of distribution to those individual accounts? Will it be a penny for penny distribution? Will it be an administrative set aside out of the endowment and then the rest as a benefit for the savings accounts?
Assemblywoman, that's a great question, and I don't think we're all the way there yet, but I think conceptually, we wanted to figure out a way that we could find a dollar figure that works for either the initial contribution or the matching contribution. I think it gets really hard not using general fund dollars to do an exact penny for penny match. I also think we have some logistical things to work on our end, since we would be the first state in the country, and I wouldn't tell you how this would work, but mechanically we want to kind of streamline this so it's a little more effective than our College Kickstart program. As you're well aware in the Budget Committee, College Kickstart is a separate ledger account. The intention here would be to make that contribution go directly into the ABLE account, so there's not two separate accounts that are more that create more friction in the savings. So the seed money would be earning interest and then would be able to be used and saved by the individual.
Assemblywoman Benitez Thompson, do you have any follow-up to that?
Nope, that's it. I appreciate so much the responses for the record.
Any other?
Madam Chair?
Go ahead, Assemblywoman Titus.
Thank you, and thank you for bringing this bill out. It was an exciting hearing in 2019 when this bill was presented, and one of the things that I thought was possible here is that the individual could contribute to the savings account themselves. And we heard testimony, if I remember correctly, from folks that may have had a small little business that they had selling popcorn, for example, and if they earned some money, then that would be counted against them when it comes to support for some of the social services that they needed, but they could put that money into this account. Is that correct?
That is 100% accurate. Assemblywoman Titus, Erica Venice, for the record. Individuals with these accounts can save up to $15,000 a year without losing access to means-tested benefits. So we're talking about food assistance programs, Medicaid, SSI, and SSDI. If you're working, so the individual with a popcorn company whose name is Jack, you can go to jackspopcorncompany.com or stop by Assemblywoman Cohen's office. I know she's always got a stash handy. Jack can save an additional $12,000 into his account. So the real kind of benefit is to how we can get people with disabilities to start saving, but also to start working so they can live independently. And $27,000 a year is really, really beneficial and can get someone out of poverty.
Great, thank you. That's what I really thought. That was the thing that I was most impressed with this program and was so supportive of it, because it was really enabling for them to get a business going, and while they're doing that, not have any fear that they would be kicked off the welfare system or the healthcare things that they needed so desperately. So thank you for that clarification, and thank you for bringing this forward, and let's, making it successful. Thank you.
Do we have any other questions? Don't see any more. So at this time, we will hear testimony in support, opposition, and neutral. Again, to provide testimony, you must register online at the legislative website, and registrants will receive a phone number, meeting ID, and instructions to join the meeting. So at this time, if we can, and if you can remember to clearly state your name and spell it for the record, and limit your testimony to 2 minutes. Again, staff will be timing each speaker to make sure that we are giving everyone a fair and equal opportunity to speak, and we will limit this to 20 minutes. So if the staff from Broadcast and Production Services, can you please load up our first caller? I know we have a little bit of a lag, so members be patient.
Hello, caller. To testify in support of AB 62, please press *9. Once again, to testify in support, please press *9.
Good afternoon, Chair and the committee. My name is Doralee Uel Martinez. I am totally blind, and I absolutely, totally support this bill. And thank you to Eric Jimenez and Zach Conan. You guys are awesome, and awesome Assemblywoman Leslie Cohen. Thank you. God bless you. Have a great day.
And can we go to our next caller in support?
You bet. Caller with the last three of 131. Please go ahead and unmute.
One moment, Chair.
No problem.
Oops, my apologies, Madam Chair. Can you hear me?
I can hear you.
Sorry about that. Chair Nguyen, members of the committee, my name is Connor Kane. I'm CONNORCAIN, testifying on behalf of the Nevada Bankers Association in support of AB 62, and still learning how to testify remotely this session. I'd like to first say that the Nevada Bankers Association knows the importance of saving and has supported a number of banking and savings opportunities for Nevadans. We're excited to support Nevada's ABLE program as it makes sure that a person living with a disability isn't penalized because they're saving. We think the proposed changes outlined in AB 62 provide even greater assistance for some of these savings accounts. We're very proud of Treasurer Conine and of Mr. Jimenez for being leaders in this space, not only in our state, but as you've heard, influencing policy around the country. And last but not least, Treasurer Conine touched on this, but we'd like to recognize him and Mr. Jimenez. They've worked tirelessly throughout this pandemic to help countless Nevadans. They've been answering phone calls and emails late at night and working on the weekends and on holidays, and they were still able to bring forward impactful policy changes such as the one for you today. We very much appreciate them and everything they do for Nevada, and are grateful for this opportunity to testify. We encourage your support of AB 62. Thank you.
Thank you. And Broadcast Services, do we have any other additional people in support?
One moment, please, Chair.
Would the caller with the last three digits, 653, please slowly state and spell your name for the record. You have 2 minutes and may begin now.
Hello, good afternoon. Can you all hear me?
Yes, we can, ma'am.
Hi, I thought I spoke earlier before. I guess I didn't. This is Dora U.L. Martinez.
Oh, we heard you, Ms. Martinez.
D-O-R-A. Yeah, okay, because I thought so. All right. Well, I'll just spell my name for the record because I know it's unique. So it's DORA-U-C-H-E-L-Martinez. Thank you. Take care.
Thank you. Thank you so much.
Sorry about the confusion, Chair.
No, that's
there are no more callers. There are no more callers in support at this time.
Thank you. And just for the record, we started at 3:20 and I again allocated 20 minutes for testimony. Obviously, we did not need that. It is 3:26 and we concluded that. I would open it up for any opposition testimony at this time. Broadcast Services, is there anyone on the line for opposition testimony?
To testify in opposition of Bill AB 62, please press *9 now to take your place in the queue. Chair, the line is open and working. However, there are no callers in opposition at this time.
Thank you. And lastly, are there any callers in the queue for neutral?
To testify in neutral on Bill AB 62, please press star 9 now to take your place in the queue. Chair, there are no callers in neutral at this time.
Perfect. Thank you so much. And with that, I will go, actually, I will turn this back over to Treasurer Conine and Mr. Jimenez. If you would like to have any closing remarks, or if you'd like to waive them, that's fine as well.
Treasurer Conine, for the record, I do hate to do this professionally, but we'll waive them in interest of time. Thank you all for it.
Thank you guys so much. And with that, I will close the hearing on Assembly Bill 62. And at this time, I will open the hearing on Assembly Joint Resolution Number 1. This resolution amends the Nevada Constitution. And Assemblywoman Titus, would you please introduce yourself for the record and begin when you are ready?
Thank you, Madam Chair, and thank you to the members of this committee. For the record, I am Assemblywoman Robin Titus. I represent Assembly District 38, which encompasses Churchill County and parts of Lyon County. I'm introducing Assembly Joint Resolution 1, which proposes to amend the Nevada Constitution. This resolution is straightforward. It changes 4 words in the Nevada Constitution. Some may wonder, why do we need to change the Constitution to address 4 words? Well, let me tell you what these 4 words are: insane, blind, deaf, and dumb. These words are found in Section 1, Article 13 of our Constitution. The section requires the state to care for certain populations with disabilities who suffer from a mental illness. The whole section reads like this. Section 1, and this is in Article 13, institutions for insane, blind, deaf, and dumb to be fostered and supported by state. Institutions for the benefit of the insane, blind, deaf, and dumb, and such other benevolent institutions as the public good may require shall be fostered and supported by the state, subject to such regulations as may be prescribed by law. I'm aware that when the Nevada Constitution was written, different terminologies were used to describe persons with disabilities or a mental illness. However, more than 156 years after Nevada was admitted to the Union, it's time to give these words a more critical look. We should change them to contemporary language that's not deemed to be discriminatory or narrow. I propose revise this terminology in the following manner. From the insane to persons with significant mental illness, from the blind to persons who are blind or visually impaired, and from the deaf and dumb to persons who are deaf or hard of hearing. The idea to change this language in our Constitution came from one of my constituents, Mr. Andrew Campbell, who hopefully will be joining me later for this bill introduction. He works in the Churchill County Middle School as a special education teacher. Most of his students have severe and some profound disabilities. Mr. Campbell also teaches American Sign Language in an after-school program, and he's very much aware of the needs of persons who are deaf or hard of hearing. He describes them as smart, dedicated people in our society who work in banks, teachers, or engineers. His own grandfather belonged to this population and was one of Boeing's first 100 employees that designed an aircraft. I'm grateful for Mr. Campbell who brought this to my attention. Let me explain a little bit more about the details of my amendments. First, I want the new terms to start with persons. We must stop categorizing people who suffer from an illness or disability by putting an emphasis on their illness or disability, for example, the blind or the deaf. Instead, these are individuals that happen to have an illness or disability. But first and foremost, they are persons. Second, calling persons who have a hearing loss dumb in our Constitution is plainly offensive. This term must go. Additionally, many people in our society are not completely deaf, but may suffer from different degrees of hearing loss. The definition in the Constitution is too narrow, and therefore I think it should be persons who are deaf or hard of hearing. Insane is another one of those derogatory terms that I recommend replacing. We know that words matter, and when you stigmatize individuals with such a term, it may lead to negative results in the long run. Research has shown that stigmatizing persons with a significant mental illness may create barriers for them. They may face discrimination and prejudice when renting homes, applying for jobs, or accessing mental health services. Stigmatized people also are less likely to seek help, the help they need to treat their condition, which might make their condition worse. Using the term insane in our Constitution for people who suffer from a mental illness helps to perpetuate the stigma. Therefore, it should be replaced with a more dignified term, persons with a significant mental illness. Blind is not necessarily a discriminating term, but I think it's too narrow. If a person is blind, he or she may suffer a complete or nearly complete vision loss. However, this term does not include any persons who have visual impairment that causes difficulties with more normal daily activities, which cannot be fixed by simply wearing glasses or contact lenses. Persons with visual impairments may not be able to walk or read without adaptive training or the use of assistive technology. Contemporary training and assistive technology programs are for all people who have some kind of visual impairment. Therefore, this language should be updated as well. And I propose the terms persons who are blind or visually impaired. In closing, I believe we need to do a better job in making sure that we do not discriminate and stigmatize persons with disabilities or mental illness in our laws. And the first step is to ensure no discriminating, stigmatizing, or derogatory language is in our Nevada Constitution. And AJR 1 will provide for that. Please keep in mind, this resolution is just a first step. It will not apply to NRS. For example, if you do a simple search in our law, or our law library on the legislative website, you can find 67 hits with the term insane. I hope there will be another opportunity soon to clean up our statutes as well. I urge you to support AJR 1 and to end the stigmatization of our citizens in the Nevada Constitution. I might add, Madam Chair, that there has been an amendment that hopefully, a friendly amendment that hopefully your members have a copy of, the members of this committee. If not, I'm going to go ahead and read it, and then we'll make sure everybody gets a copy of this. Because from Dina Schmidt, who's administrator of our Department of Health and Human Services, Aging and Disability Division, she recommended, and I actually agree with this. So the new section 1 would read, institution for the benefit of persons with a significant mental illness, persons who are blind or visually impaired, or persons who are deaf or hard of hearing, or this is the friendly amendment, so it's not in the bill you're seeing, or persons who have an intellectual or developmental disability, and such other benevolent institutions as the public good may require. I also might add that a number of members of this body on both sides of both the Senate and the Assembly have asked to be joint sponsors with me. And if anybody wants to also be on this bill, I would welcome everybody's name on this bill as co-sponsors. This was a pre-filed bill for me, so I put it in on my own, but I think this is something we all should embrace. And so I appreciate all of your time, and I'm going to turn it over to Mr. Campbell for some remarks if we have been able to get him on. And if not, I'll take it back. Thank you, Madam Chair.
I see Mr. Campbell there, and just for the members' edification, I believe that Gail has uploaded that friendly amendment onto Nellis, so you would be able to do that. And if you are interested in having, since there will be an amendment potentially if this bill goes forward to a work session, reach out to Assemblywoman Titus if you would like to be added on to that as a sponsor. And with that, I will turn this over to Mr. Campbell. Is that correct? I see you there.
Can you all hear me? You can hear me. Okay. Thank you, Assemblywoman Titus, for initiating this process. It's one close to my heart for a few of the reasons you have shared. And personally,
so you might speak up a little bit. Speak up.
Yes. So thank you. And this matter is close to my heart. I moved to the state of Nevada, and I'm here testifying today as a citizen of the state of Nevada and resident of Churchill County. I have personally experienced total deafness in 1 year. I've had my hearing restored. I've had total temporary blindness also. I know what it's like to live with that, and it's a challenge. So the fact that you're all attentive to this matter, not only for myself, but so many members of our community and their own families, I think it will be much appreciated as this goes forward with positive change.
And with that, Madam Chair, we will happily take any questions from the members of your body.
Thank you so much. I don't see any here in the chat, but I'm just going to go to gallery view. And if you have a question, if you could just wave, or if you have a comment, we can take those at this time. Go ahead, Assemblywoman Benitez Thompson.
Thank you so much. I appreciate that. So of course, love the bill, love the language, love the intent. You know, I don't often talk about it, but I was diagnosed with my hearing loss at 30 and told that I would, you know, VDEP within 20 years, and I continue along on that progress. So I am one who definitely does not like these types of adjectives to be applied to me unless I've really earned them in certain instances. So I appreciate this. I'm wondering about the conforming language that where you talked about a change in statute. So this is a change to the Constitution and it will take some time. And I guess I'm wondering if we have a successful constitutional change at that time, is that the time where we would look at NRS for the conforming language to make sure we're lining up with our statutes? I just didn't know in terms of process if that would have to be like a proactive BDR, or if once you get a constitutional change, it kind of rolls out on the back end.
Yeah, great question. I think I'd like to turn it over to our legal counsel to answer that question, because the process for this, and I think all the members probably recognize the process, that the change in this, that's why I'm open to suggestions on getting the wording correct, because whatever the wording is has to be matched next session and pass again, and then it has to go to a vote, change our constitution. So it's so critical that we try to get it as right as we can. And then I know there's been sessions in the past, I think 2011, and maybe Mr. Campbell can look into that, because I know there's been some in the sessions in the past where we changed some of that wording regarding insane, and we've changed definitions, but we haven't gone through the whole NRS and then retrospectively changed all that wording, and that would take a different bill. That's certainly, than I think that this would do, and maybe our legal could to tell us what we could do.
Ms. O'Krent, are you on the line? Do you have?
Yes, I'm here.
Oh, wonderful. Do you think you can answer Assemblywoman Titus's concerns, or would you need some additional time to look at that up?
I think I can address concerns now. So typically, if we're making a change like this in a bill, we would include something that would authorize us to make the additional changes in NRS when we're codifying things. But because this is a bill that deals with a change to the Constitution and will have to be passed by another legislature and then voted on, at the time that it's been voted on, we would need to make the changes pursuant to a separate bill that would then make the proper changes in NRS.
Thank you.
Do we have any other questions or comments? I see in the chat that we have Assemblyman Hafen said that he would like to be considered as a co-sponsor as you're going through the potential amendment process. I would like to be included in that as well, if you do end up doing that. And I've, like I said, all the members that are on here, if you are interested, I would encourage you to also reach out to Assemblywoman Titus as if you want to be included in that as well. Oh, I see Assemblywoman Gorlow on there as well in the chat. Do we have any other questions though for Assemblywoman Titus or Mr. Campbell? Okay, wonderful. Then with that, we will go to hear testimony in support, opposition, and neutral on AJR 1, and we will start with testimony in support. So I know, again, we have a little bit of a lag time between this, so if we can be a little patient while Broadcast Services sees if we're ready to go on support testimony first.
Testify in support of AJR 1. Please press *9 now to take your place in the queue. Caller with the last 3 digits, 120. Please slowly state and spell your name for the record. You have 2 minutes and may begin now.
Good afternoon, Madam Chair, members of the committee. Stephen Cohen for the record. Ditto both the sponsor and co-presenter's remarks. I do have one other friendly amendment, but I will address it offline with Madam Sponsor. With that, thank you, Madam Chair, and I yield.
Thank you. And Broadcast Services, we go to the next caller.
Yes, Chair. With the caller with the last 3 digits, 956, please slowly state and spell your name for the record. You have 2 minutes and may begin now.
Good afternoon, and thank you, Chair. My name is Liz Davenport, LIZDAVENPORT, the legal legislative extern with the ACLU of Nevada. As this bill removes derogatory and offensive language and provides modernization to the Nevada Constitution, we support AJR1. Legal terms must be updated so that they foster respect for people. Much too often, derogatory terms have been to foster incorrect negative social stigmas. The American Psychology Association's Committee on Disability Issues has emphasized the need to avoid offensive expressions and recommends placing people first, just as Assemblywoman Titus explained. Further, when derogatory terms remain in statutes and constitutions, judges, lawyers, social workers, institutions, and others are then unfortunately compelled to apply these pejorative terms when applying the Constitution. The United States Congress recognized this over 10 years ago, and in 2010 and 2012 removed similar derogatory terms such as lunatic and mental retardation from the U.S. Code. Similarly, as this bill removes derogatory and offensive terms from the Nevada Constitution, we support AJR1. Thank you for your time.
Thank you for your testimony. Do we have anyone else on the line in support?
Yes, Chair. Would the caller with the last three digits, 611, please slowly state and spell your name for the record. You have 2 minutes and may begin now.
Good afternoon. This is John Piro, John Piro, on behalf of the Clark County Public Defender's Office and the Washoe County Public Defender's Office. As lawyers, we understand that language is important, and the language that Dr. Titus is seeking to change in this bill is stigmatizing and detrimental to people in our state. We thank Dr. Titus for bringing this legislation forward, and we echo the statements of the ACLU. We support this bill, and thank you for your time.
Thank you. Do we have any other callers on the line?
Yes, Chair. Would the caller with the last three digits, 291, please slowly state and spell your name for the record. You have 2 minutes and may begin.
Hi, my name is Beth Jones, and I have two callers on the line that both registered for testimony today. I'm going to first introduce my son, Harrison Jones, Harrison Jones, Jones.
Good afternoon. My name is Harrison Jones. I am 9 years old, and I live in Henderson. I am hard of hearing, and I'm representing myself in court of AJR1. I don't think that people called deaf or hearing to be called deaf and dumb. It's because it makes me feel like I'm stupid. I'm a AB honorable role at lacrosse team academy. I'm a blue belt in karate and an after in deaf and hard of hearing fetal program. And I'm the opposite of dumb. I am small. If you are deaf, you can do anything anybody else can do but hear. Being deaf does not make you dumb, and it's just wrong to say thank you and have a good afternoon.
And here is our second testimony. Hi, my name is Alexis Jones. Alexis, ALEXIS, Jones, JONES. I am 13 years old and I am from Henderson, Nevada. I am representing myself in support of AJR1. I have severe to profound hearing loss in both ears and wear hearing aids. The term deaf and dumb should not be applied to deaf and hard of hearing people because we are like everyone else. I've been in National Junior Honor Society for 2 years. I have gotten straight A's in all of my honors classes for all of my years in middle school so far. In elementary school, I won gold medals in the Science Olympiad. I was a tour guide for the McCall Street School of Mines and continually in the honor roll. I testified for a different bill 2 years ago when I was 11 regarding deaf and hard of hearing kids. And I signed with Assemblywoman Titus 2 years ago when my family attended Children's Day at the legislation. I was in Girl Scouts for 5 years and have been in the media PR team and have served my community.
On top of that, I have been playing soccer for over 10 years. When I am older, my goal is to be on the U.S. Women's National Deaf Soccer Team. I am an avid reader and can read over 1,000 words per minute. I have also been a part of a theater group for deaf and hard of hearing children for over 6 years. I applied to a magnet high school and will be finding out if I got accepted next month. I can do many, if not all, things that hearing children can do, so the term deaf and dumb is not applicable in this situation anymore. Not that I was right to call deaf and hard of hearing people that term in the first place. I am proud to be hard of hearing and in the deaf community and to be here testifying to update disability-friendly language. While being hard of hearing has its setbacks, it has lots of advantages too. If I had a choice to have normal hearing, I wouldn't take it. Having hearing loss is what made me the person I am today, and I wouldn't change that for the world. Thank you to Assemblywoman Titus for sponsoring this amendment and for allowing me an opportunity to speak, and have a great afternoon.
Thank you so much. Sorry, teared up here. Do we have any other callers in support, Broadcast Services?
We've had some new callers join, so I'm going to see if they would like to testify in support. To testify in support of AJR1, please press *9 now to take your place in the queue. With the caller with the last 3 digits, 584, please slowly state and spell your name for the record. You have 2 minutes and may begin now.
Thank you, Madam Chair. My name is Jennifer Richards, Jennifer Richards. I have the pleasure of serving by appointment by the governor as the Chief Elder and Disability Rights Attorney for the Aging Disability Services Division. Our agency supports AJR1, and we are thankful to Assemblywoman Titus and this committee for shining a spotlight on this issue. The language that we use matters. The terms currently in our state constitution are pejorative, they're offensive, and they are a reminder of a very dark chapter in our state and nation's history for persons living with disabilities. It was a time of compulsory sterilization laws, discrimination, lack of accessibility, and other atrocities. The United States Supreme Court upheld compulsory sterilization laws for those with intellectual disabilities in Buck v. Bell. The court held that persons with disabilities do not have a fundamental right to make private decisions regarding their family lives. In delivering the decision, Justice Holmes declared that 3 generations of imbeciles is enough. The use of this term emboldened other states to adopt compulsory laws, and it perpetuated further marginalization and discrimination of persons living with disabilities for decades. Since that time, passage of the UN Convention on the Rights of Persons with Disabilities, the ADA, and other important legislation have helped usher in a paradigm shift from viewing persons with disabilities as objects of charity, medical treatment, or social protection to full and equal members of society with fundamental human rights. All of us at ADSC and DHHS as a whole care about the people that we serve in our state, and we strive to use appropriate, person-centered language when providing those services. Again, we are very thankful to the Assemblywoman and the committee for addressing this issue. Thank you.
Thank you. Do we have any other callers? You said that some other people had jumped on.
Chair, we just had some other people jump on as well. To testify in support of AJR1, please press *9 now to take your place in the queue. With the caller with the last 3 digits, 724, please slowly state and spell your name for the record. You have 2 minutes and may begin.
My name is Jamie Stetson. I work for Renovation Mental Health Services. I also work for Nevada Equine Assisted Therapy, and I also work with Victorious Care, which is an SRC SLA provider. Across the board, I work for several different kinds of people who have different kinds of disabilities. And I also have children who are on the autism spectrum. This bill and changing the language throughout our revised statutes is so important to legitimizing and to taking away the stigma for people with disabilities in our community. I can't tell you how much I see on a regular basis where we have a significant lack of providers. We have a significant lack of ability to access resources in our community, and having this kind of language still be in our revised statutes and this kind of language still being used across the board in our state, it's shameful, and it's something that needs to be taken care of. And I'm really, really grateful to see that something is being done about it. I strongly support this bill and any kind of bill that gets rid of the disgusting language that is used and that also supports people and creates less barriers to access and, just shows our community members that we support them. We have a hard time doing that in the state of Nevada, and continuing to do so in ways that are meaningful is really important. I appreciate the time that you have taken to get this put forth. Thank you.
Thank you for your testimony. Can we go to the next caller in support?
Chair, there are no more callers in support at this time.
Okay. Can we open up to see if there's any callers in opposition?
To testify in opposition of AJR 1, please press *9 now to take your place in the queue. Chair, it does not appear that there are any callers to testify in opposition.
Are there any callers in testimony that want to testify in neutral?
To testify in neutral on bill number AJR 1, please press *9 now to take your place in the queue. Chair, there are no more callers in neutral at this time, and the public line is open and working, and I do not think that there are any more callers.
Thank you so much.
Chair, you are currently muted.
Yes, I am. Almost the whole meeting without doing that. Anyway, I would, Assemblywoman Titus or Mr. Campbell, do you have any closing remarks at this time?
Well, I would just like to say thank you all. As I put in the chat, I've never cried during a testimony before, so I actually shed a tear with that one. I didn't realize I would get emotional about it. I was a little surprised at myself. So I just want to thank you for hearing this bill. I appreciate it. As you can hear from the testimony, how important it is. I thank all members have reached out, and I will put your names on. And when you hear this bill again, hopefully in a work session, we'll add those amendments. And so I just want to thank you. I want to get it right. So if there's other suggestions, I'm open to them. As you know, as you can hear, we need to fix this. So thank you for all your time.
Thank you so much for your presentation. And I would encourage members to reach out to Assemblywoman Titus as she's working through this and preparing it for any potential work session in the future. Anytime we have those constitutional changes, we want to make sure we get it right. Otherwise, it just slows up the process of any kind of change on these issues. And with that, I will close the hearing on AJR 1. And at this time, I'm going to ask, do we have any people on the line for public comment?
We do have another caller.
So at this time, I will remind the callers that are in the queue that this is public comment. So try to, again, state your name and spell your name clearly, and limit your comments to hopefully things that are not about the bill, but about other areas of public comment. And with that, we'll go to that caller.
With the caller with the last 3 digits, 442, please slowly state and spell your name for the record. You have 2 minutes and may begin.
Hi, Madam Chair. This is Nicole Willis-Grimes with the Ferrara Group, NICOLE. Last name is Willis-Grimes, WILLIS-GRIMES. And I do apologize to the chair and the members of the committee. I could not get my fingers typing fast enough to dial in support for AB 62. And I recognize, Chairwoman, that you would prefer for public comment to focus on issues other than the bill, but I appreciate the opportunity to be able to just very quickly voice our support on behalf of Special Olympics of Nevada. Special Olympics of Nevada is dedicated to enriching lives of children and adults with intellectual disabilities through inclusive sports, education, and health. We very much appreciate the treasurer and Mr. Jimenez's efforts on doing a fantastic job on inclusive policy, especially financial inclusivity, and really appreciate on providing a kickstart possibility for the ABLE account. So thank you very much.
Thank you. I know that we're trying to be as flexible as possible. Sometimes it's a little bit more difficult when we're in this virtual and telephonic world. So yeah, so that's fine. Do we have any comments from the members before we adjourn?
Madam Chair, we do have another caller that wishes to speak.
Oh. Look at that. They get on there so quickly. Why don't we go ahead and go to that caller then?
Okay, caller with the last 3 digits, 653. Please slowly state and spell your name for the record. You have 2 minutes and may begin now.
Good afternoon. This is Dora L. Martinez again. I was going to do the support, but I wasn't fast enough. I love these Zoom meetings because I can cook and talk at the same time. I really appreciate you, Dr. Titus, for recognizing, and Mr. Andrew Campbell for bringing that forward. I mean, after 30 years of the ADA passing, I'm glad that we are on the right path. So thank you for your time, and thank you for recognizing that people with disability are people first. We all have different abilities, and people with disabilities are resilient. You might learn something from us. Thank you so much. Have a great day.
Thank you. And do we have any other stragglers on the line?
Let me check just in case. If you would like to participate in public comment, please press *9 now to take your place in the queue. Okay, Chair, the public line is open and working, and there are no more callers at this time.
Okay, wonderful. Do I have any comments from our members before I adjourn the meeting today? Well, I wanted to thank you guys all for being so patient. I know that I packed a lot in on this meeting, but I will say that this does conclude our meeting for today, and our next meeting is not scheduled until Monday, February 15th at 1:30 p.m. So all this hard work on this Wednesday afternoon will pay off that you won't have to come here on Friday afternoon. So with that, the meeting is adjourned.
Thank you.
Thank you, Chair.
Thank you, Chair.